Today's Lunch and Learn session number 13 is on new psychological treatments for chronic pain with Dr. Drew Sturgeon. Really quickly, my name is Tiffany and I'm a study coordinator at the Health Equity Corps. We are a group within the Chronic Pain and Fatigue Research Center that focuses on elevating the voices of patient communities in research in order to raise awareness about different health inequities and community needs. So together, myself, my director, Rachel, and my project manager, Vivian, work together to bring events like this to the community. I'm joined today by Megan, who will be helping monitor the chat. So feel free to use that function or raise your hand to be unmuted. The Health Equity Corps is part of the Chronic Pain and Fatigue Research Center, or CPFRC for short. The CPFRC at the University of Michigan is a world-renowned research center composed of investigators and clinicians who study the mechanisms and most effective treatments for chronic pain and fatigue, including conditions that have chronic pain and fatigue as core symptoms. We aim to do a couple of different things, including improving the understanding and management of chronic pain conditions, as well as providing current evidence-based information to the public. So we don't only study folks that have diagnosed chronic pain conditions. Instead, we're interested in anyone who's experiencing chronic pain at all. And with that, I will pass the discussion to Dr. Drew Sturgeon.
Hi, everybody. As Tiffany mentioned, my name is Drew Sturgeon. I'm a pain psychologist and a clinical assistant professor at the University of Michigan. Let me just share my screen here. Tiffany, is that coming through? That was okay? All right, thank you. So I'll start here with, so as a background, I've worked with people with chronic pain for about 12 years in clinical practice. I have made the study and treatment of pain the primary thing I do in my career. That being said, most people don't know that pain psychologist is actually a job. So, and a lot of the natural first question I get from most people is, well, what does psychology have to do with my chronic pain? So we'll talk about some of that. Some of you may already know the background, some of this here. So we'll try and tread a little old ground before we get into the new stuff. But my hope is here to provide you an overview of where the field's been and where it's going. And we've got some pretty exciting results than thinking about pain maybe in a slightly different way than you've been told in the past. Although I'm certainly very open and interested in any reactions you all have. All right, so let's start with some of the basics here. In general, pain is what we define as a complex or multifaceted signal. And if we look at the largest pain research group in the world, the International Association for the Study of Pain, or IASP, defines pain as not just a sensory signal. It also includes cognitive components and emotional components, and actually, as of a few years ago, social components, which means that pain is more than just that throbbing you feel in your elbow or the burning you get in your hand when you lean on a hot stove. It also means that pain teaches you things, sometimes useful things like don't lean on a hot stove, but sometimes less helpful things like don't exercise because your back will hurt. It also comes hardwired with an emotional component. So nobody experiences pain without any emotional component to it. And in the acute case where you are experiencing something damaging or dangerous, that's really helpful. Now, what we've started to recognize more broadly is that even that doesn't fully explain what pain is, that pain changes as a result of our social environments. So we see this with, say, kids that are getting an injection, or a blood draw where they're afraid of needles. When there's a loving parent there supporting them, it modifies how much pain a kid can feel. So broadly, we think of all of these things contributing to pain, not equally among all people. But if we want to fully understand what pain is, those are the things that we kind of try and keep in mind. Now, I want to acknowledge here that sort of the older definitions of pain, acute and chronic. Hopefully, you've all heard these terms before. Acute, the way we use the term acute pain is actually a little bit different than you might get in other fields of medicine. Acute doesn't refer to severe. Acute refers to short term and what we might call useful. If I break my ankle, it should hurt. That lets me know that something's damaged and that I should lay off of it, let it heal, and let it recover. That's what acute pain is. When pain is chronic, meaning lasting longer than 3 months, we often think of that as being no less real than acute pain is, but often less helpful. That even if my pain started with an injury or an illness, if it goes on for more than 3 months, leaving it alone, trying to rest and let it heal doesn't tend to do anything. It doesn't tend to help because the research generally that we have outside of rare medical conditions is that if something is damaged, leaving it alone and letting it heal only works for about 3 months. At that point, it's sort of as healed or stabilized as it's going to get. So we tend to think of this as overprotective pain. The signal's no less real, but often it's on a level higher than you need to keep your body safe. What comes with that is actually some really interesting research that's emerged in the last 10 years or so, which is that when we look at the severity of structural damage that somebody has, it tends to be stronger in acute pain than chronic pain. And in chronic pain, it's actually a fairly weak relationship. So if we look at somebody's X-ray or their MRI or their CT scan, the severity of the structural damage that we see there doesn't tend to predict how much pain people have overall. So it goes in both directions. You can have a lot of pain with limited or no significant findings on imaging, but also you can have a lot of imaging findings that suggest something is wrong and not have any pain. So this table you see on the right side actually is from a famous study that was published about 10 years ago in people who don't have any pain. So these were asymptomatic people. And what you see is rates of significant spinal findings. So people who had what a radiologist might identify as significant disc degeneration or disc bulges or other spinal structural problems. You can see it's a significant portion of most of these. And as it goes on, when you get past the 40s and 50s, there's really high levels of a lot of these conditions in people that don't have any pain, which means you can have structural damage and actually not have a lot of pain. That doesn't mean that the structure of your body doesn't matter at all. That's not actually the implication, but rather that damage itself is only a piece of the picture. Another one of my favorite findings has just been republished recently, is that for people who have herniated discs, when we look at large-scale research, about 70% of them actually end up spontaneously reabsorbing into the spine. So they end up not being permanent or long-lasting, meaning that your body actually adapts. Even if there are structural problems, they won't be there forever. And even when they are there, they're not necessarily very powerfully related to chronic pain. We actually see some of the same things in osteoarthritis. The severity of cartilage loss or other things doesn't actually predict as reliably how much pain somebody has as you might think. So my analogy here is structural damage is like one ingredient. If you're baking a cake, looking at if I'm looking at somebody's X-ray or their MRI and trying to predict how much pain they have is like looking at a bag of flour and knowing how the cake's going to taste. Doesn't mean that it doesn't matter. It means it's only one piece of the picture. So we have this kind of older model called the biopsychosocial model of chronic pain, and it's kind of meant to explain how a lot of different things can contribute to pain. Things like nerve input from structural problems, changes in how the brain functions, medications, deconditioning if the body's really stiff or weak. It tends to mean that the body doesn't compensate as well. If there are structural problems, then we get more pain. But it also includes things like how we think about pain, our emotional states, our memory, and broader things like social support, access to care, our relationships. And some of these things will actually end up being really pertinent to some of the later points. But this, by the way, is about a 50-year-old model. So we have known for a long time that the best way to understand pain is by looking at it through a series of lenses. It's more than just bodily damage. So one example of that, this one is actually about a 30-year-old model we call the fear avoidance model. And so let me walk you through this. If somebody has a new injury and they end up with sort of recurrent pain after that injury, there's two paths that people might take. The one that tends to show up a lot when people have chronic pain is pain teaches you to avoid things that otherwise keep your body healthy, like physical activity. So I might experience severe back pain or knee pain after an injury. And if I keep waiting for it to get better, and I go months and months and months and months, and it's not getting better, the longer I wait, the more that some of these negative problems might start to sneak in. So if I don't move my knee or my back for a year, It might get weaker, it might get stiffer, I get deconditioned, I might get more depressed, it might screw up my sleep. And there's actually some evidence that the nervous system itself gets wound up because we're not challenging it anymore. And the more that we do those things, the worse pain gets. So it gets itself stuck in a loop. So in a lot of the frontline treatments we've had for like the best practice models for pain management since about the 1980s has been at least partially in rehabilitation. That if you have a musculoskeletal problem in particular, one way that we think you can get better is by being more physically active and keeping the nervous system calm as you do it. That's what the right side of this figure looks like. And there is, by the way, research that supports this. So this is one of my own studies, but there's a variety of others out there. Looking at people who presented for treatment at my old job at the University of Washington in their pain clinic, we had about 660 people that filled out their version of like a data registry. So we looked at their pain, their function, their mood, every time they came in or with some regularity when they came in. And we looked at the people who actually did improve from their first appointment to an appointment about a year later. And in the people who improved about a year later, we looked to see what predicts your likelihood of getting better. So first, what we found was how much pain you had in the first visit did not predict how well you did in other domains. So your likelihood of getting better in terms of function or mood was not dependent on how much pain you had to begin with. But the inverse was true, meaning the people who had higher levels of mood problems, including PTSD symptoms, sleep problems, and those that were more severely deconditioned or not as physically active, tended to get less pain improvement in the future. So the message from this sort of a study is, in a lot of cases, when we look at pain treatment, we're trying to fix things around pain, not just because we don't, not because we don't think we can fix pain, but because by doing that, we can actually improve the likelihood of you getting more pain relief in the future. So we refer to pain sometimes as a lagging indicator that your function or your mood or your sleep or your overall well-being might improve before pain does. And I'll explain the reasons why in a little bit. So some of the more recent neuroscience research tells us that the way that we might better understand what pain is and what the brain is doing is that pain is actually a response to threat more than danger or more than damage. And if you've had, say, chronic medical conditions, you've had chronic illness, you've had repeated injuries, what can happen is, as the brain detects, so nerves pick up that you might have damage in some part of your body, and those nerves fire and signal to your brain over and over and over again. The brain can kind of get used to that. It can start to anticipate that that part of the body is going to be in danger again in the future, and can send pain even after that injury or illness goes away or gets managed. So in some cases, it's almost like the brain stops listening to the body because there's been so much training telling it that the body's in danger. So the idea is the brain learns to overprotect based on prior experiences where the body's been in danger or been threatened. So I like to use an analogy here, okay? Because when I start talking about this, one of the first things people say is, "Oh, you're just telling me my pain's not real." That's not true. I want you to think, everybody here, I assume, especially those of you that are currently on Zoom, you're all familiar with how microphones work, yeah? So a good microphone does two things. The first is pretty obvious. It picks up what it's supposed to pick up. If I'm talking into a microphone, you should be able to hear me, right? But a good microphone also filters out the stuff that you're not supposed to hear, right? Anybody here ever dealt with a Zoom, somebody who's on Zoom or on a microphone that's way too sensitive? You can hear them talking, but you can also hear them moving around in the chair or somebody moving around in the background or the dog barking. All of those things are real, but you don't necessarily need to hear them as the person hearing this information from the microphone, right? That's how pain works too. So acute pain is when the mic is working properly. It is telling you accurately that there is something wrong in the body that you need to protect and let heal. In chronic pain, it's often that it's picking up things that are there, but aren't necessarily meaningful for you. It could be that signal is being amplified just because the system isn't working properly. In both cases, you're getting the same volume. The signal's still real. It's just not helping you. So the idea is sometimes with chronic pain, we want to turn down the sensitivity on that microphone. It'll still pick up if there's damage, but we don't want it sending you signals because there's a slight problem that is in no way dangerous to you. So one example of this, one kind of far example of this is what we call nociplastic pain. Nociplastic pain is a subtype of pain. It's a term that some of you may have heard before, but maybe some of you haven't. We usually refer to this to conditions where we think pain is caused not by tissue damage or damage to a nerve, but by changes in how the brain and central nervous system are communicating with the body. So it's not about damage, it's more about almost like the nervous system in the brain being wound up and not recognizing the difference between when the body's safe and when it's not. So conditions like fibromyalgia are considered to be nociplastic. It is important to know, though, it's not just conditions like fibromyalgia. There's actually increasing research that says in any condition, if you have arthritis, if you have back pain, if you have multiple sclerosis, your brain might over time start to develop this part of pain where it's the brain itself changing and learning to overprotect you. Okay. Now, our research on this is still building up. We don't have a ton of research on this yet, but what we see thus far is that there's a bunch of things that can cause conditions like fibromyalgia or nociplastic pain on top of a structural problem. And those things include genetics. There are family histories of things like fibromyalgia or migraine that play in, disruptions in sleep or other health behaviors. So exercise and like substance use seem to play a role. If you've had chronic medical illness, like I described, that repeated sort of shock to the system can teach the brain to overprotect you. But it can also happen for reasons like life stress, particularly chronic or intense life stress or trauma. Now, as you all remember, I'm a psychologist, so you probably guessed we're going to talk more about this last one. But I want to be clear, some people who develop these conditions have no history of chronic stress or trauma. It is not the only method by which people get these conditions. But many people with particularly forms of chronic nociplastic pain do have these histories of major stress or trauma. And it turns out that plays a big role in how we provide best practice treatment for them. So a little primer. We know that in particular, if you've had really significant challenges in childhood, things like abuse or neglect, severe issues with safety or stability in your housing or your food, severe economic deprivation, those things actually predict a greater likelihood of you having chronic pain as well as a variety of other health problems in adulthood. So stress and trauma that are at sort of really significant levels seem to do something to the nervous system and increase the tendency of it to get overprotective. It's also true to some degree with adult, traumas and stressors you experience in adulthood, but it's often not as strong. Now, one of the important things here is just because you had a stressor or a trauma does not mean that it's a guarantee you're going to end up with chronic pain. A lot of people recover from trauma, particularly when they've got good support and significant safety that comes after that. If I'm in a bad car accident, but I'm also getting support from my doctors and my family and my friends, and I've got an appropriate treatment plan, it's entirely possible that my body and my nervous system will recover really easily. But in many cases, people don't unfortunately have that. They end up with levels of in the aftermath, like leading up to and through a period of time after a major trauma. If there's a high level of stress, it makes it a lot harder for the body and the nervous system to recover. So we need that safety, we need that support in order to bounce back, but unfortunately, sometimes it doesn't happen. And especially if what we're talking about is people who experience major stressors that go for a long period of time, we see that there are some indications that they might still have, that the nervous system hasn't fully recovered from those things. So some of the tendencies that like clinicians who do this work look for are people that are really perfectionistic, or sometimes what we call goodists, people who end up treating everybody else better than they treat themselves. those that are still stuck in really intensely harmful or threatening or stressful relationships, those that have significant mood problems like depression or anxiety or PTSD, and also those who maybe just don't go anywhere near emotions at all. If it's hard for them to recognize emotions, particularly emotions like, grief or anger, those are usually signs that something could have gone wrong as far as a major stressor, and it can do a lot to sort of mess up the abilities of the brain to recognize safety because it starts to fear its own signals. So at a high level here, if we think about the stress and trauma kind of research that exists, the presence of a stressor or a trauma actually isn't a very good predictor of whether people get chronic pain. But when people go through situations where it's harder for them to recover, say they don't get good support, they're kind of continually in danger or under significant stress, the nervous system doesn't respond as effectively. It doesn't bounce back as effectively. So when we're looking at treatments here, one of the things we're looking for is alongside chronic pain, if you have some of these other characteristics, if you've got significant mood problems, especially things like PTSD, if you notice that you're highly fearful of pain or of movement or of relationships and emotion, we think that those are things that can actually be treated to make it easier to get reductions in pain. Or if there's long-term significant problems in relationships. Okay. So a little background here. Like I said before, a lot of people don't know that pain psychologist is even a job. And off the bat, it can be kind of confusing to be told, all right, well, you have back pain, go see a psychologist. The thing to understand, and this is again backed by about 40 years of research, the best practice model in chronic pain is multi-method. It's multidisciplinary, which means we work on hitting pain from multiple angles. That might include things like medications or medical procedures. It also means physical therapy or exercise, especially if there's deconditioning or the body needs to move. And psychological treatments, where you work on stress, you work on emotions, you work on trauma, you work on sleep. The idea is not that these things replace the medical treatment, but that they complement them. They go together. By doing these things together, we maximize the chance that you get meaningful reductions in pain and other symptoms like mood or sleep or your ability to function. So we're going to jump into now some of the newer treatments, but just a little background here. And this is kind of a high level overview of how pain research looks. So if we look at the broad clinical trial research, there is no treatment that works for every person with pain, even within the same condition. If we looked at headaches, if we looked at back pain, if we looked at fibromyalgia, there is no treatment where 100% of people respond. And that's because there's a ton of differences that people bring to the table that actually let us know that it may be more than what's going on than just what we see on an X-ray or an MRI. So good clinical trials answer a few different questions for us. How many people amongst a given group actually show response to a treatment? When they respond, how much do they respond? Are we saying they get 5% pain relief? Are they getting 100% pain relief? Are they getting some level in between? We also want to know, what are the risks or the side effects of the treatments that they're getting? If you have a chance of getting 20% pain relief, but there's also a chance it'll cost you $500,000 and you can't move for 12 months. You as a person seeking treatment really might want to know that. And so that also occurs, kind of related to that is, do people with pain actually identify a need or finding these treatments relevant and useful? It's also important to know in pain, we often focus not just on the intensity of pain itself, but also on other things like mood or function for the reasons I described before. That focusing only on pain doesn't give us a good picture. That if we really want to get a sense of how people get better long term, we have to look at these other domains as well. But it also makes it harder to get simple answers when we say, does a treatment work? As I mentioned before, most things don't work very well if you just do one treatment. They often work better when they're done in concert with one another, like I described. The other takeaway here, particularly as we start to talk about some of the psychological treatments, it is not the case that every person needs a given treatment. Okay. The questions we're trying to answer are, who benefits from specific treatments, who needs some of these things, and who doesn't need it at all, okay? So everything that I've said thus far might be true of you or somebody that you know with chronic pain at a broad level, but it doesn't mean every single person needs the treatments that I'm describing. Okay, that's why we keep doing research on it. So what you see on the screen are the kinds of treatments that we use as psychologists or mental health providers that we know can either improve pain or improve like the things that pain can negatively impact. So it might improve your mood or your function. The most common one is one that we call CBT, cognitive behavioral therapy. Basically, it's a broad toolbox of skills that you can use to reduce stress in the nervous system or help you sleep better or move better or deal with negative thoughts and emotions that come up around pain. There are meditation-based strategies. There's an approach that kind of combines meditation and CBT that's called acceptance and commitment therapy. That's really more about learning to be flexible when pain shows up so that it doesn't mess up the most important things you want to be doing. So there's a big focus on what you want the rest of your life to look like and reducing the impact that pain has on that. And we're not going to talk about any of these, but there are dozens of studies or more in each of those treatments that I just described. Hypnosis is also kind of a unique one where it's paired sometimes along with the other treatments. When we say hypnosis, we're not talking about stage hypnosis where they train you to cluck like a chicken when you ring a bell. It's more like a deep relaxation state that you can use to either reduce pain or the emotional impact of pain. The ones that we're going to talk about today, because a lot of these other ones on the screen are well established. They've been studied since the 70s, 80s, or 90s. We're going to talk about the ones at the bottom that are a little bit more focused on this idea that what's really happening is that the brain has learned to overprotect you. And so what's missing is training around safety. The brain has lost the ability to tell the difference between when you're safe and when you're not. And if we get that back, the pain can decrease as a result. So we'll start with the bigger one. This therapy that you see on the screen is called Emotional Awareness and Expression Therapy, or EAET. So unlike some of the other things that we focused on that were maybe about physical activity or stress directly, it's more about processing the negative effects that major life stressors or challenges or relationship difficulties have had in your life. And the model says that what can happen is there's an overlap between the pain circuit and emotional circuits in the brain. So when there's a lot of high intensity negative emotion, particularly that hasn't been resolved or processed, it can kind of sneak its way into the pain circuit. Where if you have long-term anger or grief that hasn't been resolved, that can feed in and make the brain feel unsafe. And because safety is what the brain uses to determine whether or not you need pain, it's a reason you end up getting chronic pain. So the therapy focuses on things like processing of anger or fear or guilt or shame or other emotions that have come up around, say, complicated relationships or trauma, or in situations where you've been in chronic stressors and you've then learned maybe to not treat yourself very well. You know, you might come out of years and years of a really negative or abusive job where you come out and now you don't treat yourself as well as you used to. So the therapy itself focuses on a few different things. One is about kind of relearning to recognize and express emotions as healthy, normal parts of being a human being. This is done through things like journaling or expressive writing where it's not for anybody else. In cases where people have current, like interpersonal conflicts or problems in their relationships that are causing significant emotions and stress, we work on communication around those things to try and to reduce the emotions and reduce the pain. And in a lot of cases, like I described, it ends up being about compassion as well. So learning to be kinder to yourself, because when people go through these really prolonged or intense periods of stress or trauma, sometimes their ability to care for themselves changes and it gets worse. And we know that without it, it's really hard for the brain to find safety. So EAET has actually been the existing research on EAET across pain conditions is looking better and better, okay? So the first big famous study that was done in fibromyalgia. And for people with fibromyalgia, we saw about 3 times as many people getting significant pain reductions from the therapy, meaning people that at start got about 50% relief in their pain or more, compared to those that even went through a frontline treatment, one of the most common pain treatment, which is CBT. So about 22% of people with fibromyalgia that went through this therapy reported at least 50% reduction in their pain symptoms about 3 months later. And there's been a very recent study, and I'll actually spend a little more time on this one, that was done in veterans, like older veterans with musculoskeletal pain. So it wasn't even necessarily something we thought of as being nosoplastic. And in that population, it was about a third of the veterans that got at least 50% pain reduction, and 2/3 got at least 30%. So this is, again, just with a single therapy, not speaking at all to anything else that they were doing, only this therapy. It was also notable because this is that study was the first to show that the effectiveness was better for people who had not only chronic pain, but high levels of depression, anxiety, or PTSD. There's never been a study that showed that before. So for people with high levels of pain and high levels of emotional distress, this might actually be the best treatment we have. We saw similar kind of powerful effects in people with irritable bowel syndrome. And there was an internet-based version of this that was published a few years ago showing about 20% of people that went through this therapy online also got 50% reductions. So remember, this is not by itself a multidisciplinary therapy. It's a single therapy, but we're seeing big levels of response among at least some people going through it. It does not mean everybody needs it. There are plenty of people in these trials that ended up maybe not showing that level of effect. But if you can make a third of people better with a single therapy, we tend to think that's pretty impressive. So that veteran study that I described is actually on the screen here. This is like from the abstract. This was published in the Journal of JAMA, the Journal of the American Medical Association. As I said, the boxed areas here are the things to highlight. Not only did EAAT do better than another treatment that we know works in terms of reducing pain, but it also improved mood problems. It also reduced depression, anxiety, and PTSD symptoms in a group that historically hasn't shown that level of benefit. So by no means is all of this definitive, but to this point, we don't have a set of studies that look quite as strong as this. So at the very least, this tells us that if we're looking at evaluation of chronic pain and how to treat it, we have to think about stress, trauma, and emotions, because for some people, they end up playing a pretty powerful role. There's another therapy I want to describe here, and this one actually got a lot of press a few years ago for what they call the Boulder back pain study. So the therapy itself is called pain reprocessing therapy. Basically what it is, it's based on the idea, like we've been talking about, that pain occurs because the brain thinks that you're in danger. And so it's very directly about teaching the brain safety through sort of calming exercises towards learning to experience pain as a safe brain-based signal, and through gentle exposure to the things that the brain is scared of, like movement. So there is to date only one trial that has been published in this therapy, but it is maybe the single most successful pain trial we've ever had. So it was 150 people in Boulder, Colorado. A third of them got this therapy. A third of them got sort of like a sham injection. It was for like expectancy reasons. And then a third of them basically got nothing. It was like a treatment as usual condition. Of the people who went through this therapy, 2/3 of them were pain-free or 1 out of 10 pain at the end of the treatment. And most of them maintained that a year later. So 2/3 of the people that went through this 8-session, 4-week protocol were basically pain-free. Now, to this point, this is the only study that has ever shown this level of effectiveness. I know they're still doing more research in it. It also required people to come in for 8 treatment sessions over 4 weeks. So it's hard to access. We don't know that it works in every condition. This was only in chronic back pain, which, by the way, was probably nosoplastic. That's kind of what we're suspecting about it. So we don't know if it works at all in other conditions. But to this point, there is at least evidence that this specific focus on teaching the brain safety by reducing fear and reducing threat can reduce pain, sometimes in very meaningful ways. Now, just as a little plug, I've developed a brief version of PRT, of pain reprocessing therapy, that we're actually starting to test in veterans with chronic low back pain. So it's a 3-session protocol. It's all done remotely via Zoom. And so the idea is we're enrolling 40 veterans over the next probably year and a half. If you or somebody you know might be interested in a study like this, we're looking for interested veterans. That doesn't involve any visits at the University of Michigan. The whole thing is done remotely. It involves filling out 35 days of brief daily diaries, answering some questionnaires up to 6 months, 3 treatment sessions, and then a post-treatment Zoom session. So if anybody's interested, the email's on the screen here. You can also find us on the U of M Health Research posting. This one wasn't listed, but it's kind of a newer study that sort of is interesting. It combines the EAAT and pain reprocessing therapy principles. This was done, I think, through part of the Harvard system. This was in about 20 people with chronic back pain. When they used sort of this education around pain is a safe signal, and they worked on gentle desensitization to physical activity, and they worked on emotional expression and some meditation strategies. Again, we saw about 60% of people getting either totally pain-free or 1 out of 10, and that was maintained 6 months later. So the research is still very much developing. It takes a long time to run studies like this, and there is definitely a group that does not respond to this. But it's exciting to see that some people are getting much, much, much better. So in summary of what I've told you thus far, the takeaways that I hope you take from this talk today: pain, particularly chronic pain, is not actually a very good indicator of damage in both directions. With acute pain, it works a bit better, but when you've had pain for more than 3 months, we start thinking about other things like stress or trauma or the movement of the body that end up mattering more. So this idea of nosoplastic pain is probably something that you'll hear more about if you work in a pain field or you yourself are getting treatment for pain, because the research hasn't really caught up to the clinical reality, which is that any condition can develop this on top of whatever the medical problem is. So when we think about treatment, the best models are the ones that treat the body and the brain. So in some people, this safety learning, the reduction in threat, the processing of emotions or stress or fear can have a powerful effect on pain. We don't fully know who will respond to these things yet. That's why we keep running clinical trials. But among those that actually seem to respond, we see better responses to this therapy than we do for a lot of the other things that we've historically done for pain. So at the very least, it's worth continuing to study to see who can benefit. So the other analogy I often offer people here is think about anything that you might get as far as a behavioral treatment or a psychological treatment as part of the toolbox. It does not mean that you can't still work on, stretching or mobility or medication or heat or ice. This is a thing that you add to your toolbox that might help speed up the process by which you get pain relief. So for anybody who's interested, there are actually resources online for a lot of what I said today. EAAT has a couple of, there's a website, which is unlearnyourpain.com, as well as a couple of the books here. One is for clinicians, it's hidden from view, but the one for people with pain is also called Unlearn Your Pain. There's a PRT book, a pain reprocessing therapy book called The Way Out that was published by Alan Gordon, who was intimately involved in that one PRT trial. That's also the name of their website, so it's not hard to find. If you Google pain reprocessing therapy, this will almost certainly be the first thing that shows up. And there's also some more general pain education websites that are free to access, the US Pain Foundation and tamethebeast.org. And that's what I have for all of you. So if there are any questions, I'm happy to answer them.